time for our last keynote speaker for today. Professor Mehmet Gunay, also working in School of Physical Education and Sport of Gazi University, like Professor of Physiology Exercise, and he was an ex-rector of that university, and talking about the athletic heart and prescriptions of coronary heart risk.
First of all, I would like to thank organizing and especially Martin British organizing invitation. I'm very happy to be here and to be part of your conference. And our subject again, cardiovascular system and cardiovascular health. After Mr. Hoffman, also after Zorba, and I must, my last speaker, and I'm very grateful to the last speaker. Let's talk about our subject. Physical activity or regular exercise is pressure load, but especially in sport we say, anaerobic training or power or speed training is leading to hypertrophy of cardiac muscle and especially endurance training, increase of volume of left ventricle. So we can see in cardiac muscle or cardiac fibrils, protein synthesis and thickness fibrils in contracted element in each fibril. But endurance training increases left ventricle and diastolic volume, but no major change in wall thickness. Internal left ventricular and diastolic diameter or dimension is about 10% larger in endurance athletes than in sedentary. So ventricular volume differences will be seen in 30%. The internal dimension of the left ventricle increase mostly due to increase in ventricular filling. So heart is find too much blood in left ventricle. Isometric and anaerobic exercise increase more degrees and also left atrial and ventricular dimension are consistently increased in subject with left ventricular hypertrophy. Now, there are some parameter of cardiovascular parameter, and that ventricular intervention with a diameter in marathon runner between 48 to 49, you see, but short motor point bracelet is about near to 48. That ventricular volume in marathon runner 154 and in bracelet 101. Stroke volume also different per activity. In marathon runner 160 and in bracelet you see 75 milliliters. So dynamic and isometric training cause an increase in absolute left ventricular mass, but only endurance training increase mass, cardiac mass, normalized with respect to lean or total body mass. Now we are looking some parameters of cardiovascular system, and some of them increase and some of them decrease. Now we are looking at these parameters: cardiorespiratory endurance, muscular endurance, aerobic power, heart rate, heart volume, heart chamber size, and left ventricle wall thickness. Also we say atlas heart, left ventricle and diastolic volume, stroke volume, ejection fraction, parasympathetic activity or vagal tone, blood plasma volume, red blood cell volume, hemoglobin concentration, muscle force and contraction, cardiac output during maximal exercise, blood flow to muscle, increased capillarization of the training muscle, opening of existing capillaries, effective blood redistribution, total blood volume, oxygen delivery, release of antidiuretic hormone, plasma proteins. And these parameters by the help of exercise, resting and submaximal heart rate, blood viscosity, sympathetic activity, expend less energy by contraction during the muscle systole, heart rate at recovery and time, blood viscosity, resting blood pressure, and systolic volume. Okay, now we can look at athletic heart. What is the athletic heart syndrome? And how do we define it? How does an athlete get it? And is it good, bad, or desirable? We know intensive regular physical exercise or training is associated with a physiological increase in left ventricle wall thickness and cavity size and mass that have been known as atlas heart. But before, we must know the first criteria of athletic heart must be changes in heart rate. We say this symptom, everyone know sport bradycardia or exercise bradycardia. And the other changes related to left ventricle. Training in general reduce sympathetic activity or increase parasympathetic activity in hormone. So this means decreasing of heart rate, and it is sport bradycardia. Also, exercise has a positive effect for decreasing blood pressure, also in normotensive people, also hypertensive subject. An increase in parasympathetic activity and or diminished sympathetic activity has been associated with training bradycardia. Long-term activity causes morphologic, functional changes in the heart characterized as left ventricle cavity dimension changes, wall thickness and mass increase, and little condition changes. This condition is identified as atlas heart syndrome. The changes that are seen clinically occur as a result of physiological adaptation to training. Cardiovascular adaptation depends on the exercise type as well as its frequency, duration, and intensity. The cardiac remodeling in athlete is correlated aerobic capacity or aerobic power of athletes. In isotonic exercise, we increase cardiovascular volume growth by increase to venous blood return to the heart. A maximal isotonic exercise causes 2 times increase in stroke volume of the heart. As for the isometric exercises, they cause cardiovascular pressure load by increasing systemic blood pressure. With isotonic exercise, approximately 10% of increase in left ventricle means 30% of increase in left ventricle and diastolic volume. The wall thickness and the ventricle diastolic diameter increase, the mass volume ratio remain stable, doesn't change. There is a sudden increase also in blood pressure, myocardial contractility, and cardiac stroke volume as a result of catecholamine, in other words, adrenaline and noradrenaline, that increase during exercise and the nerve signal caused from muscle reflexes. With isometric exercise, in the blood pressure response can reach to higher blood pressure levels than seen in isotonic exercise. Due to this pressure load, the wall of the ventricle thickens. Also during isometric exercise, the venous return doesn't significantly change. Therefore, the diastolic diameter of the left ventricle does not significantly increase. Because of this, with athletes whom the diastolic exercise, the mass volume ratio has increased. Athletes who have larger body mass, the cardiac volume and the left ventricular muscle mass is greater. The older athletes have more significant myocardial hypertrophy due to duration of active exercise time being longer. In other words, sport time is sport time. Also, women athletes have less cardio hypertrophy than men. This is physiological differences. There is a significant rest bradycardia and lower systemic blood pressure in athletes as a result of physiological hypertrophy. Maybe cardiologists get third sound or fourth sound as an examination with the echo. This may not have a clinical importance, maybe in asymptomatic children. Another problem in athletes, electrocardiographic changing. So the athletes electrocardiography may show quite a bunch of differences compared to a sedentary person's electrocardiography. The changes seen in electrocardiography have developed secondary to increased vagal tone coming from vagus nervus and decreased sympathetic tone and physiological hypertrophy. The most frequent findings in sinus bradycardia at rest, especially in sleep recordings, less than 30 beats per minute. So that time maybe we must use electrical devices for as a stimulation to synaptic node. First degree atrioventricular block might be seen in 30% of the athletes. The mechanism here again depends on the deceleration of conduction velocity in the arterioventricular node due to increasing parasympathetic and or decreasing sympathetic tone. And also, as T wave changes consistent with early repolarization are seen in more than half of the athletes or 50% of the athletes and are closely related with the athletic activities, duration and intensity. And another problem that we see in athletes, echocardiographic findings. In the echocardiographic examination of the atlas, when atlas are compared to control group, the left ventricle mass is approximately 46%, left ventricle cavity measurement 10%, posterior septum thickness 14%, and anterior septum thickness is 19% is higher. In dynamic exercising athletes, an increase in the diastolic diameter is noted in left ventricle compared to control group. The diastolic diameter of the left ventricle was found in normal limit in 55% of the athletes. Mean value is less than 54 millimeter. And generally, left ventricle septum and posterior wall thickness increase accompanies the dilation of ventricle cavity dimension in atlas. It is very important to differentiate the septum thickness increased cases from hypertrophic cardiomyopathy because it is the most frequent cardiac reason for exercise related sudden death in young aged athletic group. The additional direction of the large ventricle cavity between 55 to 63 in atlas who have a septal thickness of 12 millimeter is a finding which suggests that the hypertrophy is physiological and it is important to differential diagnosis. Now we are looking to different heart. The first one is normal heart, and the second one hypertrophic cardiomyopathy diseases. And what can we do, or what do we have to look for deciding an atlas heart? The first criteria must be resting bradycardia. So, atlas has a decreasing resting heart rate, nearly 60 per minute is enough for us because we look someone heart rate if less than 60, we can easily say yes, he is physically active person or he is maybe athlete. But second question must be echocardiographic findings. So the first criteria must be left ventricle diastolic diameter and must be less than 55 millimeter because in hypertrophic cardiomyopathy diseases is less than 45 millimeter. And third is we must look septal thickness. If less than 12, it means yes, this kind of findings say us this is athletic heart. It's more than 50, right side. This is the symptom of hypertrophic cardiomyopathy diseases. And between 30 and 50 millimeter, we need these findings give us the next idea. We must look another criteria, and the golden, we say in Turkey, golden criteria. If this person is athlete, must be high level of aerobic capacity. And we look aerobic capacity, and if someone has aerobic capacity, aerobic power more than 50 milliliters per kilogram per minute, this means yes, this is athletic heart. This is very easy way to differentiate athletic heart from hypertrophic cardiomyopathy, but we need good echocardiographic result. And the other parameters say, and differences man and woman, the differences between man and woman, for man 12 for septal thickness, for woman 10 or 11 can be reading there. What is important of athletic heart? Or what is important of hypertrophic cardiomyopathy for us? What they say to us? What do we evaluate this finding? We say there is one problem in athletes. The genetic abnormalities most associated with sudden cardiac death are cardiomyopathies, especially hypertrophy. The best pressure question is that prevention of sudden cardiac death in athletes is dream or reality. Today, we have several major troubles for solving of the question. Large population, discordance between phenotypic and genotypic expression of genetic cardiovascular diseases, no gold standard testing, and standardization for evaluation, cost effectiveness are some of the troubles. The one fact in the description of the athletic heart that has not changed is that the utmost important factor in preventing cardiovascular events, especially sudden cardiac death, is the appropriateness evaluation. The right time for evaluation of appropriateness of sport is pre-participation. So we need first the athlete's medical history, exercise-related chest pain or discomfort, syncope or presyncope, unexplained dyspnea or fatigue, hip murmur described before, direction of high blood pressure. We have time? Sir? We have time?
5 minutes.
5 minutes. And we need family historic information, presence of early death from cardiovascular diseases, disability before age of 50 due to cardiovascular diseases, hypertrophic cardiomyopathy, delayed cardiomyopathy, Marfan syndrome, arrhythmia, canalopathy. In physical examination, hearing movement in the heart, pulsophiato that suggests aortic coarctation, high blood pressure, and suggestion. European Society of Cardiology suggests resting electrocardiography to be used for appropriateness of sport examination as a routine. It is accepted that electrocardiography is more cost effective than other tests in detecting cardiac pathologies. Echocardiographic examination is added in routine evaluation program when competitive athletes have any cardiovascular symptoms. Furthermore, duration of referencing heterogeneity should be measured during exercise testing for detection high-risk subjects. And I want to give last my speech because my second part of presentation nearly same with Mr. Hoffman and Mr. Erdal. Take your patience and again I'm very happy to be here and also say voila, voila, voila.
If you have any comments or questions, please address it to our keynote speakers. We have a speaker, please.
Maybe a short comment. As as I mentioned before, we did some 24-hour exercise in ultra endurance athletes, and what we could see in these athletes is, and this is well known, that the heart rate decreases during the exercise. So at the end of 24-hour exercise, the heart rate is lower than at the start with the same exercise.
Yes.
And the reason is not a cardiac fatigue. Somebody think about that.
For suddenly.
It's not. It's a change of volume. So you have a large shift of volume into the whole body, and you increase the preload.
During the exercise, yes.
I'm sure that this type of exercise is producing big hearts.
Yes.
So the volume overload, we can measure this volume overload, and of course you need long distances.
Preload or afterload? Which one? Preload
The
or afterload?
The preload.
Preload. Yeah, flexible mechanism. Yes.
So you fill
I agree.
heart,
Yes.
and of course this makes these large hearts. This is the positive side.
Yes.
On the other hand, if you look at old athletes doing endurance exercise at that extreme, they have a double, 2 times higher risk to get atrial fibrillation in old age than the normal population. So it looks like that you get some changes in the ECGs.
And they say in Turkey, athletes should not retire sport. Athletes do exercise until that. The reason for this. Okay, thank you very much.
Yes, that's right.